you, sir. Good morning, everyone. How's everybody doing? Great. I am delighted to be back in Toronto. This is my hometown, and it's always a thrill to be back here. So today, I've been asked to talk about the quality and responsiveness of health systems. And specifically, what's different and why is this a relevant issue in the Sustainable Development Goals era? So I just want to get a show of hands. How many people have heard of these Sustainable Development Goals? Okay, great. So you're well up to date. This is a very knowledgeable audience. I won't even go into the 169 targets or hundreds and hundreds of indicators. But they are very relevant to us because they are, as Professor Bhutta just said, meant to lay out the progression, the goals, the vision, the aspiration for the next 15 years. So where do health systems fit in? I will only talk about three things today. I will talk a little bit about quality and why quality is more critical than ever. I'm going to make the case to you that people, including poor and illiterate people, demand quality, and that when they don't get it, they act in ways that are entirely reasonable, actually. And that last point, that while both of those things may be true, we know very little about quality and much more about many other things that don't necessarily contribute directly to health. So let's start with the first point, and quality and its critical importance. So you are all familiar with the Millennium Development Goals as well, right? That's the previous generation of goals that were just completed in 2015, at the end of 2015, so just a few months ago. And you note also that of the MDGs, a large chunk was devoted to health. Health was a really important issue. Health, however, was focused on really three areas: maternal health, child health, and a few infectious diseases. That was the entire portfolio of global health concerns in the MDG era. And now, seemingly, we've really lost some leverage in health because we're down to one goal, right? We're down to one goal, but that goal is a very big goal. It's better health. It's really a goal about good health. So before I proceed, let's link this back to health systems. So many of you are child health experts. What are the sort of main interventions that you know of, that we know of as a globe, for reducing child mortality? Just throw out some answers. What are the top things you would do in a country with high mortality? I hear immunization. Trained health workers for what? Oh, sorry.
Life-saving interventions, quality care.
Okay, very good. Yep. Clean water. Yep. What are the best buys? Yeah. Sanitation. Yep.
Surveillance systems.
Can you expand?
So tracking what's happening within a particular patient or in a particular population.
Perfect. Very good. So you're spoken like an epidemiologist. Nicely said. Okay, surveillance systems, water, sanitation, immunization. Anybody else with an intervention? What else are we? Yes.
Fiscal management.
A health systems person, perhaps, or an economist. Very good. All right, one last go. Yes. Nutrition, crucial, right? So what we feed children, what they drink, sanitation, their home environment, all critical. But out of all those things you mentioned, only a very small minority were actually in the health system, if you think about it, right? Most of the production of child health actually happens in the home and in the community. And the health system is critical when that child gets sick with severe malaria. But it isn't essential to many of the other pieces of child health. So I think that explains, in some ways, why we've done so well in child health. We have, as a global community, focused our action and our attention on many of those determinants of health that happen in the home. So what's going to happen going forward as we look over at the next 15 years? This is actually the set of targets inside that one single health goal. So you can see that we've gone from maybe 3 or 4 things to think about globally to this larger list. That's one big difference. Another big difference between the MDGs and the SDGs is that the MDGs were about them. They were about poor countries, lower income countries that were highly dependent on donor assistance. SDGs are explicitly about all of us. So when you look at that list, I bet you're going to see things that are very pertinent to you living in Toronto today, right? Getting trauma care if you get into an accident, having good psychiatric care if you come down with depression. All of those issues are now the issues of all of us. So the scope and complexity of global health issues has really dramatically changed. So we're in this unprecedented transition from a very small, discrete set of targets to a much, much larger, more ambitious set. And I've circled a few here in particular that I think require particularly complex interventions that cannot be done through just a single shot in the community, that cannot be fixed through better water, that really need a competent health system. Things like someone, again, with an injury who needs trauma care. Maternal mortality, you all know that the only way to save mothers is through emergency obstetric care, which requires identification of the condition, requires being able to know what to do, hazardous chemicals and pollution. All of these require many more complex services. So all of that then implies a much greater demand being made on the health system. So we're shifting the focus from community to the health system if we have any hope of achieving these sustainable development goals. What do we need in the health system? So wearing my clinician hat, one thing we need is differential diagnosis, knowing which fever is malaria, which one is pneumonia, and which one might be Ebola. We're working in Liberia today where those mistakes were made early on. In many cases, were not diagnosed properly. Why? Because those health workers were only trained to recognize malaria. So differential diagnosis, screening, monitoring, lifestyle modification. Remember the non-communicable diseases on there? They can't be solved through a pill. We need to have people change their lifestyles. That requires skills. Emergency care, trauma care, psychotherapy, and dealing with substance abuse, which is a huge issue back in Massachusetts where I am. So this, I would propose, is the first law of health systems. What is the entire purpose of the health system? Well, the contractual deal that we have with the population as health systems people is the following. If you come and use our services, right, we'll provide good quality care, and then you're going to come out healthier than when you came in. That's the basic deal. So we're asking for you to trust us, use the system, and get better. That's all there is to it. All right, so let's see. Where has our focus been to date? Up to 2015 with the MDGs, I'm arguing that almost the entirety of our focus has been on this first part of the equation, on utilization. We've been working very, very hard to figure out ways to get people to use services, people in lower income countries, getting skilled delivery rates up much, much higher, getting all the kids immunized, right? Getting kids to services, getting moms to services, getting adults to services. And so what's evolved as a measure of this is a huge sort of industry and a large academic and research focus on measurement of coverage. So what I'm showing you is data, as many of you are maybe familiar with. This is part of the work on the countdown work and the maternal and child health monitoring work that's been going on globally. Of course, Professor Bhutta has been intimately involved in that. And what you can see here is just wonderful graphics showing where people are and are not getting coverage, utilization. So oral rehydration therapy, sorry, this is not working so well up here, is about 50th percentile across 54 countdown countries, 54 of the countries with the highest mortality. And what you can also see with these dots, which I think is really, really important, is where the poor faring versus the rich in those same countries. So you can see one of my favorite indicators to look at for that is the skilled birth attendant rate, where you see massive discrepancies between poor women and rich women in the same regions of the world. When I talk to ministries of health, I always say, you can't tell me that you can't get skilled deliveries up, because I know that your urban women are already at 80%, so you've done it. You've already got models of success in your very own setting for the rich. Now let's see if we can generalize. So this is what we've been spending 15 years doing, measuring coverage. Critically important. Measuring coverage. And you know what? What gets measured gets done. If we care about coverage, simultaneous with the measurement efforts have come efforts to get people into the system. So what have we done? Can you guys think of any sort of interventions out there that we've been trying globally to encourage people to use healthcare? What are some of the tools and strategies that we've employed? Yeah, so what are community health workers? They talk the health system up. You need to come if your child's sick. Absolutely. What else? That's right. If you insure people, they don't have to pay out of pocket. That's absolutely right. We've done community insurance. In some cases, countries are moving toward universal health coverage to try to reduce the costs of care. What about vouchers? We've been giving people vouchers to use private clinics or use transportation. You guys know about conditional cash transfers, where if you use the clinic, you'll actually get money. We've been paying people to use health systems. So we've spent a lot of money and energy on getting people into healthcare. And so what we see as a result of those efforts is pretty impressive gains. These are just two pictures out of the MDG 2015 Endline report. Globally, we've gotten skilled delivery rates up from 59% in 1990 to 71% in 2014. Global measles vaccine coverage has gone up as well. A number of other things, care seeking for pneumonia, have gone up. We are getting really good at getting people into healthcare. That's a great accomplishment of the MDG era. And it's also not enough. It's not enough to get to health, because if you remember, the second part of that equation is all about quality. So when those kids get to the clinic, when those moms get to the clinic, what do they get when they get there? What is the quality of the service they get there, and is it sufficient to enable them to get better? So let me, before I get into showing you some data on quality, let's just define it for a moment so we're all on the same page. One thing I hear from colleagues a lot is quality. What is this fuzzy quality thing? Quality is everything. Many issues can be bundled underneath that. So I have a sort of a fairly simple approach to it in that if you look over here, on the left side of this, there are a number of inputs that are required to have a quality health service, right? You need competent workers, you need the stuff, the equipment, you need supplies, medicines, and so on. You need good management. And also, all of that has to be then converted into action. When the patient comes to you, what is the health worker able to do? And I would suggest the health worker has two important tasks. They're complementary, but they're not the same. The first is to provide good technical quality, meaning following evidence, right? Doing things quickly when a child is very sick, making an effort and not just sloughing off that patient in 2 minutes. Many visits in low-income countries take 2 minutes with the health system. So you need technical quality, which is the left side of this. But equally as important is the patient experience. The patient has to be respected. We have to give them confidentiality. We have to be very careful about how we communicate if those prescriptions are going to be taken correctly, right? So that's the patient experience. So there's two pieces of quality: technical quality and the patient experience side. And then if you do all that right, ideally you get better health out of that equation, out of that visit. You get satisfied patients, and they might come back. So there's actually a virtuous cycle, right? If people get what they want, they might come back. Now you might say, well, is this all theoretical, or do you have some proof? And you should be asking that question. And I'll show you some evidence around that. But let me first show you a few glimpses of what it is we know about quality globally. So up here, I've put up a few figures. Let's start with the first one, 42%. So 42% is the average rate of correct diagnoses if a patient with chest pain, unstable angina, walks into a primary care doctor's office in India. That's the chance that you will be diagnosed correctly that you might be having a heart attack. So it's a little less good than a flip of a coin for that patient, okay? 2 to 3 times, what is that about? Well, a very interesting study done in 23 countries in hospitals. These are not the first level poorly equipped clinics. These are hospitals. Found that although the hospitals claim that they have all of the interventions required to save a mother's life, magnesium sulfate, oxytocin, they've got the monitoring, they've got the nursing staff, they've got doctors, they've checked off all the boxes on a checklist, turns out that the mortality rate of moms who come into those facilities is 2 to 3 times higher than all the modeled predictions. Now, let me just assure you, the first thing I hope you're saying as you're thinking through this critically is, well, in higher mortality settings, the moms are sicker, right? When they reach the clinic, they're sicker, so of course they're going to have a higher mortality rate. They may have traveled from far away, there are other diseases, and so on. No, these figures already control for that. The modeled mortality already takes into account that the moms are going to be sicker in high mortality, low-income countries. So above and beyond that, those facilities are hugely underperforming women. 19%. This is our own study in Tanzania, where we found that during labor and delivery, approximately 1 in 5 women experiences at least one event that could be described as disrespectful or abusive. So a mom in a delivery, an incredibly happy moment, a moment of childbirth, might experience being shouted at, ignored when she needs help, I think the third item on this list is particularly poignant. With all the effort we make to get women into health facilities, about 4% deliver by themselves in the end anyway. Nobody attends that delivery. Right? 2.5% are shouted at. And what you see with the blue bars here is that we went back to these women, a subset of these women, in the community 6 weeks later. So we got the red bars by interviewing women on exit, after delivery, in a separate place from the clinic, because we wanted them to be as unbiased as possible. But still, it's tough, right? The mom is exhausted, and she might want to be positive about that experience. When we back to the community, we saw even much higher numbers of these really distressing experiences. And there's a respectful maternal care movement building globally based on figures like this one. This should not be happening to people. Do you think that mom is going to come back with her child for immunization if she's experienced this in childbirth? All right, so let's come back to this model, because I actually think quality buys us something else. I think if people consistently experience good quality in the health system, a provider that respects them, that takes the time to communicate, it also builds trust between the individual and the system. You know, you might feel like the system is there for you and you can count on it. These are data from Liberia, a study that we did back in 2008. And as I often say, we just published because a doctoral student was in charge of it. It took a little longer. But it came out at just the right time, because it came out as Ebola was hitting Liberia. In 2008, we asked a simple question to the population of Nimba County, the largest county in Liberia. We said, if you or your child got very sick tomorrow, would the health system be there for you? Can you trust the health system to help you? Just about half the population said yes. And the other half have no confidence that the health system would be there for them. So is it therefore surprising that when the government started putting out messages to the community, please, the moment you have a fever, come to the clinic, that the population ignored those messages? They don't have faith in the health system, that it's not there for them, it's not there to help them. And when we did analysis of where this opinion comes from, right, why are people not trusting, we found that the experience from the last visit that they had with their health provider was a big determinant of trust. Not, by the way, the number of medicines, not whether the building was close or far, the clinic building, but what happened to them in that visit. Okay, so hopefully I've persuaded you somewhat that quality matters. Let's talk about how people in the community see quality. So for some years we've been borrowing a technique that marketing experts use. Before a cereal is put on a shelf, people are extensively tested using this sort of a methodology where they're given 2 different cereal options. And maybe one of the cereals is, you know, round or flavored with fruit, and the other one's got this shape and it's got raisins. And so different attributes of the cereal are presented to focus groups, and they're being asked to choose which one they might like. And from those kinds of choices, the manufacturers select a product that will meet the greatest, you know, will have the greatest uptake. So we actually borrowed that, and economists use this all the time in transport economics and in environmental economics as well, where people don't directly pay for things, but they still value them. So here is an example of a stated, they're called stated preference experiments, of an experiment that we did in rural Tanzania, in western Tanzania, where what we did is we said to women in the community, look, let's imagine for a moment you have 2 clinics to choose from for delivery, specifically for your next baby. So only women who said they are going to have a next baby were selected into this. And we said to them, you could go to clinic A, that's an option. You're going to meet a doctor there. There will be a doctor at that clinic, but he won't be very happy to see you. And there may or may not be equipment that day or drugs. It's unclear. It's actually the reality, by the way. You don't know if that day there will be equipment or drugs. But you'll notice that clinic is only an hour's walk, and it's got an ambulance in case things go wrong. You see the ambulance there? So these cards are accompanied by a standardized script. On the right-hand side, instead you have a nurse. You guys can probably figure out the rest, right? She's friendly, she's got medicines. It's a much farther walk, 3-hour walk. It's much more expensive to get to that clinic, right? And we give women about 8 of these cards with different choices, okay? And from this, let me ask you, before we go on to the next slide. You are a rural Tanzanian woman, 50% illiteracy rate. What mattered to you out of all of those things I just presented about choosing a delivery clinic? What were the driving factors that really made you decide? And what's wonderful about this methodology is it forces you to make trade-offs. You can't have everything, as you can see from these cards, right? You can't have everything you might like. You might like a friendly doctor, but that's not a choice. So those forced trade-offs give us researchers a lot of information about what matters to people. So what mattered to people? Any guesses? Distance. I thought so too. I came into this thinking, there's no way anybody laboring, I've had some babies and it's not easy. You don't want to be walking 3 hours in labor. That's an awful thing to consider. What else?
Maybe choosing female.
That's a great point. Turns out Tanzanian women do not care. Ethiopian women do, but Tanzanian women don't. But that's something we tested even before this experiment. It's just the reason that there's a female and male is because all the doctors are male in Tanzania and all the nurses are female. Yeah.
More medicines and equipment available.
Absolutely, that could be important. And you had a
Warm reception.
warm reception. Okay, so let's pause on that and go to the answer. So these numbers are a little hard to interpret because they're utility values. The way to think about each number is the higher it is, the more benefit you feel from that one element, okay? So what do we see here? We see that the combination of provider attitude and drugs and medical equipment were by far, out of everything else on that list, the two most important drivers of choice, of stated choice. In fact, how would we understand these numbers since they're not exactly intuitive? Look at the number on provider respect. The provider smiles and listens carefully attribute had a utility value of 168, whereas having a doctor in the clinic had a value of about 30. So that's about a 5-fold difference, right? So what does this tell us? Tanzanian women don't care if it's a doctor or nurse. They care whether they're respectful, and they care whether there, as one of you said, whether there are drugs and equipment there. Because frankly, otherwise, why go? If you just want warmth, you can get a traditional birth attendant to be nice to you back in the home. So women are very clever, and they really want both of those things in the clinic, or they won't go. So we went and did a similar experiment in Ethiopia, a very different country for those of you who know, with a very low facility delivery rate. About 6% of women at the time of this study delivered in the health system. What did they tell us they valued? And this is actually, so it's a different population. And the experiment was very similar, but not exactly the same. Available drugs were a huge issue. Basically, women were deciding that, you know what, if the clinic doesn't have those drugs, that equipment, that's a signal to me they can't help me if I get into trouble. And then what I thought was particularly interesting is that women were willing to travel. Travel time increased utility. They saw travel as getting to a better place, as a positive value. And look at the last section. Anybody know what an HEW is? Anybody here an expert in Ethiopia? Yes, health extension workers. So these are community health workers, right, that are meant to provide preventive and some curative care in the community, in very basic primary care. And there was even some talk about maybe them doing deliveries. Do Ethiopian women want health extension worker to do their delivery? No. That's a negative. This means it actually takes away from their value of going to the health system. So actually they're quite picky about what it is they want in the facility to use it. And it is amazing to me that we spend all the money and effort and energy to figure out breakfast cereal, but we don't actually figure out what people who are dying, who have huge health needs, want from the health system. We hardly ever do this sort of analysis. Okay. Let's move on. So stated preference is one thing. You might reasonably ask me, well, this is what they told you and they said some cards. Will they actually go to the facility if you provide those things? Well, here's some evidence we have from a recent study in Tanzania. Economists consider bypassing a very powerful signal of preference. So let me explain. The idea is if you've got two clinics and one is right near you, let's just say I was living down the street from SickKids. My child was sick. I didn't go to SickKids. Instead, I went to some hospital in Montreal, whoever your competitor is, I don't know. That is an incredibly, you intuitively understand, right? That is a strong expression of my unhappiness with SickKids, right? There's no reason I should be bypassing such a great hospital, unless it's not great to me. Yeah? So we apply that same logic when we look at how people use services around them. And what we show in Tanzania, this is now in Pwani region, Tanzania, which is a poor rural region, that 42% of women who were within 1 hour of a facility that is equipped to do their delivery did not go to that facility instead. So that would be a facility like this, a primary care facility. Instead, they wanted to go to the hospital. So was this easy? Is this because the hospital's close? It's not. And in fact, what we found was that what was the reason for bypassing? When we did regression analysis on this, we found that women who lived near upgraded facilities and facilities that performed more complex services were less likely to bypass them. So somehow women are getting decent information about what's going on in that clinic through word of mouth, talking to other moms that have been through it. Not perfect information. There's still a lot they don't know. And remember, maternal complications and even newborn complications are relatively rare, so it's hard to get it right. But basically, they are pretty aware of what's going on. And they went farther. They traveled much further. They used cars more often. They paid more. And many more people borrowed or sold something from their home to afford that trip because they were voting for quality. And then, actually, did they get quality? I won't go through all of this on the chart, but whoops, I think I skipped one. But everything in green is our areas of care, quality measures, that bypassers received in greater amounts or were more satisfied with than non-bypassers. So if you look at this chart, actually bypassers made a pretty decent decision for themselves. They got better care from their perspective. All right, so let's move on to this final section, and this is the exciting part for me, because this is where our team are really now putting in a lot of time and effort, which is to try to fill the gap. The gap is that despite the importance of quality, we know very little about it. So I have a wonderful team at Harvard, and we're collaborating with colleagues in a number of countries to try to get a picture of quality the same way that we have a picture of coverage, right, around countries. So let me just take you down, and actually most of the data I'm showing you here, actually maybe all of the data, are as yet unpublished. These are pretty fresh data that we've really been able to pull together in the last 1 year. So let's start with primary care, because we all care about that. I'm in Canada, I'm a proud primary care doctor myself originally. And this is what matters. This is the first point of contact with the health system. So how do we evaluate quality of primary care? Well, fortunately, other people have defined these elements for us already, so we can just take them. And they're affordable and timely, effective services, and people-centered. You remember that previous framework I showed you? This is very similar to what we were elaborating there. Okay, let's look at Haiti. This is the country of Haiti. What's wonderful about Haiti, there are many things, but what's wonderful about Haiti, particularly for researchers, is that it has mapped its entire health system. In fact, what you see on this map, every blue dot, is a health facility. And guess what? We know everything about each of those facilities. There's a massive survey done in each of these facilities that can tell us about what's going on. The survey, by the way, includes observations of clinical care, where a person in the corner stands with a checklist and watches what a doctor or nurse will do. So let's find out what they do. So what we did in Haiti is we said, okay, let's start with those circles and let's look at the clinics and their distribution, but afterward, let's look at those 3 elements of primary care quality and assess Haiti on a scale from 0 to 1 on how it does based on whether it's met a number of criteria, whether the services provided are affordable to people, whether they're patient-centered. You might ask, how do you know something is patient-centered? Well, we use there's a number of, there's a number of metrics one uses, but one example would be, did the child's parent know the diagnosis when they walked out? Did they know what the child had? Simple question. What proportion of people do you think globally walk out of a lower income country clinic knowing what's wrong with their child after they've been to healthcare? Not before, after. Proportion. How many, what percent? About 45%, about half. The other half, no idea. They went to get care, they have no idea what's wrong with their child. So when we look at Haiti, what you can see here is it's reasonably affordable and timely. There is some good news, some bad news on patient-centeredness, but when you look at the effectiveness of care, whether they're following protocols, it's a nightmare. It's red, okay? So does it matter where the clinic is, or does it matter what the clinic does? So here's another way to look at the map of Haiti. What we did here is we simply highlighted the parts of Haiti that are providing effective care in all 3 dimensions. So these are the parts of Haiti that you would want to live in. Unfortunately, as you can imagine, the majority of the population does not live in those green circles. So honing in on quality across countries, I want to show you so buckle up, I'll show you a lot of data over the next few slides to make this case that some of these gaps in knowledge can already be filled with existing information, while there's still many things unknown. So we looked at a number of surveys. This is a combination of World Health surveys and service provision assessment surveys to look at safety, for example, inside facilities. So what you see here is different bars. Facility has water. This is across 5 sub-Saharan African countries. And about 40% of facilities even have water, for example. So you absolutely need that. Effectiveness, do women globally aged 18 to 69 have a pelvic exam? 1 in 5 women globally, this is based on 40 countries worth of data, have ever had a pelvic exam in their life. So how our health system is really doing for these women. And then patient-centered, is the caregiver able to choose a child's provider? Is the diagnosis known? And so on. So we see this sort of very uneven performance, and in many cases, quite poor performance. Let me get really deep again and tell you a little bit about the technical quality. What we see here is a study that's underway right now in 5 African countries, where what we found was average quality for primary care facilities in maternal care as being about 0.36 out of 1 on a scale of 1. And that scale is comprised of all of those elements you see here on the left-hand side, right? Having a referral system, having trained providers, and so on. Secondary facilities with C-section do better. And I just want to show you this. This is a relation between volume of deliveries on the x-axis and quality on the y. And what you can see is that the more deliveries, the better, right? But you can also see that the blue facilities do very poorly, and those are the primary care facilities, the facilities that do not have an OR. And the red facilities do better. And that's not because we bias the results against them. The only results on the y-axis are results that are elements that should be in every clinic, not just hospitals. All right, so you might ask yourself, well, how many babies are born in these blue facilities, poor performing? Any ideas? This is in 5 sub-Saharan African countries. What percentage of facility childbirths happen in these low quality blue facilities? Do you know how many happen in low volume facilities in Canada? Very, very few, actually, about 2 or 5% of all childbirths. So any idea there? Yeah, 40% of babies are born in facilities like those facilities. So is that okay? Is that coverage acceptable to all of us? So let's look at a few more maps. Effective coverage is this idea of coverage multiplied by the quality of that coverage. So if you have 100% coverage of something, but only 50% of the time is the care correct, then your coverage is actually 50%. So let me show you how it looks for antenatal care and for some child health issues. So first, antenatal care visit. Guess what? We've been really good at getting women into antenatal care. It's basically universal. Everyone. These are 5 countries in Eastern and Southern Africa where we have data, very detailed facility data. So we are showing excellent, excellent antenatal care coverage. Now let's weight this coverage by the quality of that coverage. So what are we doing? We're taking 40 elements from the observations of antenatal care. And this is the map that you get. This is the actual coverage of antenatal care. When you look at all the items that should have been done in that first visit, you get a map that looks very middling, right? And quite poor in places. So is this coverage effective? Are we doing the right thing for women who are getting to care? Let's look at kids. How many kids are getting good quality care? Oh. So what we don't want, right, is we don't want a child sick with malaria or seizing or dehydrated to be arriving in a clinic like this where there's no health worker. There may not be anyone there to help them. And how often is this happening? We're combining in these data demographic and health surveys together with health facility surveys and looking at what actually was done for children who came for integrated management of childhood illness care. So again, are they getting to good care? So here are 2 things we know about from the demographic and health surveys. For fever, we see very good coverage. More and more parents are bringing their child in who's got a fever. And acute respiratory infection, less good. But still not bad in certain countries. Looks like Tanzania is not doing so well. Let's superimpose now the quality of that care based on clinical observations. And this is what we see. So again, what is the point of coverage if we can't deliver on the promise of good quality? And I just want to show you, I don't know if many of you have heard of the law of inverse care. Julian Tudor Hart is a Welsh physician, well known for one of his seminal contributions was defining this notion of inverse care, which in his words was that basically poor quality follows poor people, that poor quality clusters where poor people live and better quality where rich people live. And if you look at where illiterate women live and where poor quality of care resides, it is in those same areas. And when you look across 8 countries, and the percentage of households that have a finished floor, which is a measure of wealth, and the quality of primary care available to them, you see those kinds of relationships as well. I've been asked to wrap up, and I have more things to show you, but I won't. So let's skip past these next couple of slides just showing the variation in quality. These are new data that looks at why quality varies. The importance of variation analysis is that it shows us what can be done. What's the range of the possible in the current circumstances, and trying to understand why it varies. But let's skip through that, and you guys can look at that at your leisure. I think the exciting work that we're doing now with our team is trying to quantify the penalty that poor quality poses for survival. This is work from Malawi, where we are showing all the clinics in Malawi, and we are finding all the women who delivered around the same time. So we have data on quality for the clinics, we have data on deliveries, and we have data on newborn mortality. And what we can show in Malawi is that the farther you live, okay, so on the left-hand side, the farther you live from a good quality clinic, the less likely you are to deliver there. That's why that graph goes down. But on the right side, the farther you that you live from a high quality clinic, the higher your probability of newborn mortality. So it isn't about any clinic. This is the important point. This is not about living far or near any clinic. What matters is how close you are to a good quality clinic. So to conclude, we do have data now to start examining some of these assumptions about the health system doing good. The data are partial and available only for a few countries. They come from health facility surveys. Many of them are out of date very quickly. But we can do some work on this, and our team have been doing some work on this. We do need to be able to link it better to outcomes like mortality to make the case to funders and policymakers that this matters. But new and better data are urgently needed, particularly not about stethoscopes and drugs and amoxicillin in the cupboard, but rather what happens with those inputs when the provider sees the child. That's what we need to know. Are they able to produce the kind of care we would expect? Many measurement questions are still out there. How do we define good? At what point on a scale from 0 to 1 does good start, right? That's a question we're asking all the time. And then, of course, a huge question about the best means to improve and sustain quality. But coming back to the SDGs for my wrap up here, where is quality in the SDGs? I showed you this equation. So what we did is we analyzed the SDG indicators that are out there already. They're still in the process of being finalized. And we looked at how they're distributed across this equation. What we see is there are a lot of indicators for health, and that's just as it should be. We should be concerned about the ultimate goal of health systems and of global health efforts, which is, of course, reduce mortality and morbidity. There are also a lot of indicators of utilization, actually. Still preoccupation with coverage. What we don't see is much at all on quality, right? So that is really my charge to you, to think critically about what it is we're doing in global health to achieve the future that we all want. And this is just some members of our study team. Thank you so much.
Thank you, Margaret, for that wonderful tour de force. And I'm sure people are burning with questions. So just as a point of clarification, you need to tap on your mic. And when we go across the room, I'll start from that end, move to this end, vice versa. You need to switch your mic off to let other people speak. So questions, please, for Margaret. Please. Introduce yourself.
Yes, my name is Simon Locke. I'm a geneticist. My question is, the US and Canada is spending an awful lot of money in healthcare. If you apply the same metrics for the developing country to the Canadian or the US system, how do we fare?
Should we take a few, Zulfi, or do you want to one by one?
Answer them as
Okay, great. That's a great question. So, this is an area where global health has actually a lot to learn in terms of the research and measurement from Canada, the US, and wealthy countries. Quality has been a huge focus, obviously, here, and patient-centeredness here in Ontario is, again, a new area of work and focus. I do think that there's a lot of learning to be done. Now, that's not the question you asked me. You asked, how would we do? And I think the issues of patient-centeredness and respect, in particular, are issues that we do have to work on, particularly with underserved populations, with migrant populations, with immigrant populations, because they do determine, they are part of the fabric of society, and what we promise people is this sort of a respectful care when they come to the health system. So I actually do think that that's probably where we need to do more work. There are also lapses in quality on the technical side throughout our countries, this country and the US. And I think, when we're thinking about remote areas and how we serve them with good quality care, that's an important issue. I think the other issue that we do need to guard against is the over-provision of care. So over-provision is also not good quality, right? It's the opposite of good quality. I think that's probably where the emphasis needs to be here in wealthy countries.
Other hands? So go ahead, Isaac.
Thank you very much for your illuminating talk. I mean, given that people are demanding quality and resources in poor countries are limited, should we not be changing our thinking in that rather than saying that you're going to have the facility every kilometer away, that you rather have well-equipped, good quality, fewer centers, but at longer distance, which will meet this, the demands and the satisfaction of the people.
It's like you read the conclusion section to my last paper. It's not even out yet. Absolutely. So I'm a researcher, and I'm a clinician in my past life, but I don't know what all the models that are appropriate to every context are. I don't want to come in with a one-size-fits-all solution. But let's focus on one example, which is the delivery care example that I showed you here. In that paper, what we say is, are we really okay with women delivering at a very close facility that they can walk to that provides this kind of quality? And by the way, the qualitative data behind this, I was in Tanzania last fall and sat with health workers and asked them, where did you see the last hemorrhage? When was the last time you saw a hemorrhage or a child die? They don't see enough cases to be good at this kind of care. And so I think there, what we are recommending, together with our Tanzanian colleagues who are co-authors on this paper, is exactly this model. Instead of investing in every little last clinic, little one-room clinic to do deliveries, let's take some of that money and give it to poor women so they can travel to the hospital. They already want to go there. Now, of course, that's not a perfect solution, right? Because a hospital gets overcrowded. It might provide inhumane care to people. So what we need to do is look at other models. South Africa is developing a model where maternity care centers, centers of excellence, are located across the street from the hospital or down, just down in the next building. So a sick mom can be quickly brought over for a cesarean section. A child can be brought over for resuscitation or for incubation and so on. Those kinds of models are what we need to explore. But the shocking thing to me is we haven't done so yet because we haven't looked under the surface of what goes on in the clinic.
So Margaret, we have a question from Twitter Space from Justine Beton, who's a nursing global health student from McGill. And the question is the data that you shared from various countries being used to inform the training curricula for doctors and nurses in the very countries themselves?
That's a great question. I think all of us in global health research are in part in that area for the kind of policy impact that this person is talking about. The data I'm showing with you are very fresh, really hot off the press, and we haven't had a chance yet to share them extremely widely. But I think this focus on nursing and medical education is absolutely correct. I do think right now that we are not doing a great job. We talked earlier this morning about a study from India showing fairly poor performance in some of the private medical schools that have been added in recent years. And it is really, we have just got to stop obsessing with quantity over quality because we are not fundamentally doing those patients a service. So absolutely, that's the next phase, is to share these data with policymakers.
Go ahead.
Sorry, I'm not actually at a microphone. Hi. My name is Ashley. I'm an adolescent medicine physician, and I'm actually doing my master's work on health systems from an adolescent perspective. And you had mentioned the idea of I think a lot of what you're speaking to is about relationships between patients and providers. And I'm wondering where you see the role of relationships within the health system. And sort of beyond that, it seems like to some extent, some of the trouble is sort of decision makers viewing the health system as quite bounded and quite well defined, and the priorities sort of as quite limited to things like historically like coverage and sort of number of providers. And I'm wondering if you've seen any emerging attention to the idea of involving frontline workers and patients and planners in a more sort of collaborative, relationship-based approach to addressing some of these problems. Because I imagine some of the challenges, again, lie outside of the traditional health system. If you can't retain quality providers because of issues such as remuneration, et cetera, those all feature in, but may not be sort of identified as easily by sort of top-level policymakers.
Yeah, that's a great point. I would consider, I think that's absolutely crucially important. Who better to tell you, right? This is why, I run these analyses in my office, but then I just need to go to talk to health workers and say, what are you actually experiencing? What's it like in that empty clinic by yourself when a woman comes in bleeding? Because those are the kinds of things that give us the feel, the nuance of the situation. And I think that we're doing that in fits and starts. There is more emphasis on rewarding primary, the frontline workers and recognizing them and trying to listen to their solutions. I do think there's a very large disconnect, though. We're getting good information from them between what they say and then what the system responds to. One thing I'm really cautious about is, we're always in information finding mode, but we're not in action mode. We don't react in response to that information very often. So I think workers feel very disillusioned when they're consulted. So we need meaningful consultation mechanisms that actually result in change that's visible.
Paul, did you have your hand up? Yep.
Yeah. I'm Paul, I'm an epidemiologist, and you showed an example from Haiti, a very striking example showing the effectiveness in primary health centers, I think that's what it was. Child mortality in Haiti, under 5 child mortality in Haiti has been dropping, excluding the earthquake, for 50 years. So what do you think the relative contribution is of quality of care? Clearly, improvements in population health, dramatic improvements are possible without good quality. What do you think would be added by improving quality in terms of just quantifying?
In 2 words, newborn mortality.
Okay.
Right? So you're absolutely right. And in fact, I made this point early on in my talk that I should have probably even made this point more strongly. I'm a health system person, right? That said, the majority of health is produced outside of the health system, let's face it. It's the social determinants, it's whether the mom gets the baby immunized, that could be by somebody in the community, the safe water, all of those things are the obvious important things outside of the health system. And I think a lot of child mortality, when you look at the epidemiology of the high burden countries, can be exactly dealt with there. You know this better than I do. When we come to newborn mortality, when we come to the kids with severe malaria, right, who are seizing or losing consciousness, that's when you need a health system, right? And what I think we're seeing, and I think the data back me up, is that the kids who are now sort of resistant to these community efforts and water efforts are actually the kids who are going to need competent care, whether it's intrapartum care, whether it's resuscitation, whether it's warming, all of those issues that are going to need the kind of ability to diagnose a failing child and be able to deal with it. And that's in the health system. So I think we've done well to this point, but I do not think that further progress on newborn mortality, as one example, is possible without tackling these issues.
Please go ahead.
Hi, I'm Michelle. I'm a project coordinator. Just picking up on your last slide, what would be the 2 or 3 quality indicators that you would want to see added to the SDGs? And you mentioned they weren't finalized. Is there opportunity to advocate and influence that still, or how does that work?
Yeah, we are trying. I'm on the road a lot, and so are other colleagues. So to start with the second part first, members of my team are involved in sort of the revision of data standards around what we should be collecting from facilities. We are speaking with WHO, we are speaking with UNICEF. They've heard versions of this talk without maybe some of the data that are recent. Great question, though, about what are the right sets of quality indicators. I think it'll be tough to bring it down to a couple, but I do think where they need to focus is on the process of care, that middle bucket in my diagram of what actually happens between clinician and patient, rather than, again, counting stethoscopes or counting, ampicillin tabs or whatever. That it may be the proportion of diagnoses that are made correctly. It may, now, if you know anything about measurement, which I'm sure you do, I can say that easily, but to do that is not easy, right? But we have ways to do that, actually. But it may be things like, whether for patient-centeredness, what percentage of parents know the diagnosis when they walk out, or know the instructions for how to get their child better. So there are a number of metrics that have been used successfully, but really rarely translated into this larger policy sphere.
So Margaret, one big challenge, and I'll give Stan the last word in terms of questions, is how to make a normative thing out of this. So I was fascinated by the data that you showed on your own assessments of various things within the maternal care pathway, which are not part of surveys, which are not part of the routine information systems. How do we now move forward to ensure that this moves out of the research realm into district monitoring systems, DHIS?
Absolutely.
I mean, shouldn't quality assurance be something that every district facility captures somehow?
Great question. And I would say if you asked any country, no matter how low income, whether they have a quality assurance system, they would all raise their hands. They all do on paper, right? There are a lot of policies on paper. One of the frustrations of global health is the amazing disconnect between paper and practice. But we do have a avowed interest in this, but we don't have a real interest in this in countries. Partly the data that come currently from the DHIS and the health management information systems of countries are so weak, they're really unreliable. Researchers around the world are just finding them almost useless in most cases. So I think step one, to answer your question, is to improve those systems. They've got to be picking up, right? They've got to be picking up on some of these indicators themselves. Not all of the indicators that I've shown you today are possible to collect from routine data, however. But for example, I should know case fatality rates for every newborn in every hospital in my country in real time, right? Do you know the famous story, apocryphal story goes in Cuba, that one of the reasons they brought their maternal mortality ratio really down to US or Canadian levels is that every single maternal death made its way to Fidel Castro's desk for review, right? That's accountability.
Same in Sri Lanka.
And in Sri Lanka. So those are systems that work. Those are data systems that work, and that there is a response. You see, it's not just data collection, there's a feedback loop. So I think improving DHIS, yes, but then who is going to interpret those data and act on it? Improving the Ministry of Health unit that can actually understand these data. And the third ingredient is that no matter what you do in terms of great routine data collection, you're going to need special studies around issues of respect. You can't bake all of these things into routine data collection, so you're always going to need collaborations with researchers, just like we have in Canada or the US, to look at specific issues as those come up.
Fantastic. Stan, last question.
Margaret, wonderful talk, really well presented. You've kind of answered this question before, but I'll ask it anyway. It's really an implementation question. At the Hospital for Sick Children, we are phenomenally focused on quality. And the focus really comes with sort of from two areas. One is, on an annual basis, the hospital has to put out what's called a quality improvement plan. And some components of that plan are dictated by the provincial government that every hospital in the province has to measure. So for example, every hospital has to measure the time between a patient entering the emergency department and the time it takes from that moment to the time they get admitted to the ward. And that's an access question.
That's right.
But the hospitals are also allowed to come up with some of their own improvement plans. So for example, this year for the first time at SickKids, we have a measure of the identification of sepsis for a child who comes to our emergency department. So my question is, do you think in the long run, it's more likely that quality will be a part of the nomenclature if it's coming from the top down, or more likely from the bottom up? Which is more likely to be successful?
You know, that is an excellent question, and I don't know the answer, but I think to look for clues, we should look at what has worked in other areas of healthcare. We're always learning, right? We're always learning how to do things better. I think when the Canadian system and the US health system started worrying about patient satisfaction and responsiveness, there were many reasons for that, probably simultaneously, right? People were upset, surveys were really negative, people complained. Here in Canada, people wrote to the newspapers, right? When they had to wait 3 weeks to see a doctor. Those things came from the bottom up, they were magnified by the media, and then there was a response that said, hey, not acceptable. Why? Because actually, for one thing, these people are the funders of healthcare. So if they're unhappy, we're failing them. So I do think the bottom-up piece is extremely important. And I think when parents see their child, poorly treated or misdiagnosed in the ER, and the diagnosis changes when they get to the ICU or to the ward, they note that, and they know it, and they will increasingly, as patients are connected, if they don't complain about it to your complaints board, they will put it on Twitter or Facebook, and the system will hear about it. So we're no longer in an era where patients don't get it, patients are activated, and we see this in low-income countries as well. So you need that bottom-up pressure, you need the awareness about what people should expect when they come to SickKids or when they come to a clinic in Tanzania, and those will be different things, by the way. I don't want to paper over that difference. Those will be different things, right? but we have to deliver on the level of care that we promise. So you need both.
Fantastic. Well, thank you so much for coming, Margaret, and for sharing what has been an absolutely fascinating insight into where we are going. So we've been quite privileged to hear from a global leader as to where monitoring, evaluation, and accountability is going to go. So over the period of the Sustainable Development Goals, one of the things that we are striving very hard is not to make the mistakes of the MDGs.
Right.
One is not being aware of things until it was well underway. Secondly, not being aware of many of the social determinants and underlying factors behind those. And this time, although the Sustainable Development Goals are a little bit daunting, they are so broad and they have so many
Big list.
different targets and indicators, but at the end of the day, they are also quite interconnected. And I think you've certainly touched on one of something that's at the heart of the SDGs, are the issues that lie close to service delivery quality, both its reach and what I call not just coverage, but effective coverage. So thank you so much. Please put your hands together.